Thank you everybody for coming tonight. We really do appreciate your time this evening. I'm gonna start off with just what it takes when you come into the office and what is involved with the whole process and the whole getting started. So when a couple or a single patient is coming to see us, we'll talk a little bit about what your family planning goals are. We'll talk to you and your partner about what you are looking to achieve in the future when it comes to having your family. And then when it comes to your evaluation and treatment, we will tailor it to you specifically. So when we talk about the overview of the fertility evaluation, we break it down into four main parts. The first part is the ovary. So the ovary is the source of the eggs. These eggs are fertilized by sperm. So we do an evaluation of ovarian reserve, egg count, ovulation, when it comes to that side of the evaluation. The other parts of the female evaluation involve your fallopian tubes. The fallopian tubes are basically the conduit for the eggs and sperm to meet, and for that fertilized egg that becomes an embryo to be able to travel and implant into the uterus. The uterus evaluation is also included. So not only do we want to make sure the tubes are open for potential treatment options, we want to make sure the uterus is clear for an embryo to implant. We will also evaluate the sperm or the sperm options. So we will evaluate the sperm in a number of ways. We're looking at count, we're looking at motility, so how the sperm are moving. We're also looking at the shape of the sperm. So we want to make sure the sperm is normally shaped in order to assess the ability to fertilize the eggs that you're using to achieve pregnancy. When it comes to ovarian reserve, there are a lot of traditional tests that we've done in the past. Probably the one that's talked about the most is the anti-Mullerian hormone. This is a hormone that actually comes from your ovaries. It comes from the small follicles in your ovaries that contain eggs. The more eggs you have, the higher this hormone. So we use this as a gauge to help determine a patient's response to our treatment options. It's not a predictor of pregnancy. We actually don't say that a lower reserve or a higher reserve gives you a higher chance for pregnancy. It's just a predictor of how you will respond to our medication. And we use it to help tailor what dose of medication a patient may need in order to pursue the treatment options they're doing. And obviously we'll talk a little bit more about treatment options in a minute, but AMH is the hormone, like I said, comes from your ovaries. It typically can be drawn at any point of the cycle, menstrual cycle. It tends not to fluctuate like some of our more traditional hormones like FSH and estradiol. We like to include it with another panel of tests for our patients where we're not just assessing ovarian reserve, we're assessing hormones that can also affect ovulation, such as your thyroid and prolactin. So we have a whole panel of prenatal labs that we assess for our patients that are not only for our part of the evaluation, but also thinking about future pregnancy and what your OBGYN will be managing once you leave our practice with a successful pregnancy. When it comes to the physical evaluation, we have a couple of options. The first option is actually looking inside the uterus directly and checking the fallopian tubes. So it's called a hysteroscopy. So if you've heard of a colonoscopy where they're checking your intestines, the hysteroscopy is a little bitty camera that's looking inside your uterus. So it's done as an outpatient procedure. So it is done under anesthesia. We take a tiny camera, it's smaller than a pen, and looks inside the uterus. The advantage of the hysteroscopy is not only are we able to look directly in your uterus to make sure there's nothing physical that would get in the way of a pregnancy, but if we see something, we're able to treat it. So with the hysteroscopy, we can find such things as endometrial polyps, which are benign growths that can grow into a little ball in the mucosa of your uterus. Also, we may see fibroids, which are also benign tumors, but a little bit more firm that can also impact pregnancy. And for some patients, we may see scar tissue from prior pregnancy or prior surgery. The hysteroscopies are an opportunity to not only diagnose, but also take care of anything that we see that may impact pregnancy. At the same time, we do something called a tubal catheterization. So we take a small catheter through your scope and we actually can flush the tubes and see if they are open under X-ray, because the fluid that we use to push through the tubes can be seen on X-ray. So we can actually see the tubes fill with fluid and spill. If we see that happen, that shows the tubes are open. When we do the tubal catheterization, It's only diagnostic for the tubes. So it's not that we can fix the tubes at the time. It only tells us, are the tubes open and are they healthy looking? If they're blocked, we will assess what your options are in the office. But unless we have an idea that your tubes will need further surgery, in most cases, this part is diagnostic, and we talk to you in the office about what it means if the tubes do have any kind of issue. Now, this next test is called the Histosome Pingogram, or HSG. The Histosome Pingogram is typically what a lot of patients may even have done even before coming to see a fertility specialist. It's the same type of X-ray test that I just mentioned that we do with the hysteroscopy, except it's done in a radiology suite. There's no anesthesia involved. They actually can place the catheter into the uterus and place the fluid and actually see things on X-ray really quickly. A lot of OBGYNs will order this for patients even before seeing a fertility specialist. It's done by radiologists. It's done by specialists like us at our surgery center. It doesn't take very long. These procedures, especially this outpatient procedure here, takes probably no more than 15 minutes to complete. When we push the dye through, as you can see in the picture on the right-hand side, we actually want to see the uterus form a triangle little shape in the middle and see the spillage on both sides, which show the tubes are open, and you can see the pubic bone surrounding the whole area. But that's typically what a histosome pingogram should look like when it's considered normal. The disadvantages of the HSG is, of course, we see something, we can't necessarily treat it. So we're not looking directly in the uterus. We're just kind of seeing the fluid fill the uterus, and we just, like I said, we have to just use it as diagnostic. We don't perform any removal of any procedures of any polyps or fibroids or scar tissue with the HSG. It's just a quick X-ray test. And then when it comes to the male evaluation, we are doing something called the semen analysis. So the semen analysis is looking at a few things when it comes to male factor infertility. We are looking at the number of sperm, so it's called concentration. So we're looking at how many number of sperm per volume of sperm. Concentration, we usually want to see at least 15 million per milliliter is what we consider the lower limit of normal. We also look at the motility of the sperm. So that's how the sperm is moving, or how many of the sperm are moving. We also look at how many of the sperm are moving straight, so progressive motility. And then the last thing we look at is morphology. So morphology is actually illustrated here in this picture, or the slide that you're looking at right now. The sperm all the way to the left is considered normal looking sperm, so normal head, neck, and tail ratio. All the sperm on the other side in the pink box are considered abnormal sperm. So big head, two tails. Now, when we see sperm that are abnormal, it does not necessarily mean that they're genetically abnormal, but we sometimes can think that the abnormal sperm may be a reflection of maybe lifestyle choices. For some men, we may talk to them about habit changes or even taking vitamins. Abnormal sperm may have a decreased ability of fertilizing the egg, but they don't necessarily mean that they're genetically abnormal. And we'll talk more about that depending on your outcome and specifically what your treatment options are.
So my name is Alexa Clapp, and again, thank you for joining us tonight, and hopefully you find and take away some information that's helpful. So I'm going to shift gears a little bit and talk about one treatment option. So the first treatment option would be an IUI. An IUI stands for intrauterine insemination. So this can be paired in an unmedicated cycle or in a medicated cycle. So an unmedicated cycle, a good candidate for this situation would be somebody who has regular menstrual cycles, who is ovulating on their own. So in this type of cycle, we would follow your normal follicle development. So like Dr. Nurudeen mentioned, in the beginning, we have our eggs that are housed in our follicles. So these follicles are these fluid-filled sacs in the ovary. Each month we get a group, and on your own, only one is going to grow. So we follow that follicle until it reaches a size that we would trigger your ovulation, and then proceed with the timed insemination. A medicated cycle on the other hand, would be useful for somebody who has irregular cycles, similar to the situation in polycystic ovary syndrome. So somebody that's not ovulating on their own, that doesn't consistently grow a follicle. Or sometimes we utilize it in patients with regular cycles, but if we wanted to increase the number of follicles that they were growing besides just the normal one. So this medicated cycle can be commonly paired with, and it's usually with oral medications. So you may have heard of Clomid or letrozole, and less commonly used with injection medications. So typically this type of cycle starts on your period or coming off birth control pills, or if you hadn't had a cycle, depending upon your blood work and ultrasound. You take the medication, which is usually the pills, for about 5 days, and then we see you back for monitoring visits. So the monitoring visits are measuring your body's response to the medication. And what the pills do, they trick your brain into stimulating your ovaries to grow a follicle. So the monitoring visits, we essentially measure the diameter of the follicles that grow. And once a follicle reaches a large enough size, then we would trigger your ovulation and do the insemination. So the idea behind an IUI cycle would be to get somebody to ovulate who doesn't normally ovulate, to maybe increase the odds slightly by making more than one egg, but not too many eggs, because the goal is not higher order multiples, to time egg release with sperm exposure, and to inject the sperm inside the uterus. The IUI procedure itself is a very easy procedure. It's done in the office, easier than a pap smear. You can see the illustrated picture on the left. So a speculum is placed, and then we just clean off the cervix with kind of a cotton swab, and then pass a catheter. The catheter is very thin, so similar to the size of a pin tip. So we just pass it inside the cervix, inside the uterine cavity, and inject the sperm. And then after that, your pregnancy test is approximately 2 weeks later. So each IUI cycle is about a month, mirroring your own menstrual cycle. Since everything is still happening kind of inside your body, we need one fallopian tube at least open for this type of procedure, which would be part of that evaluation that Dr. Nurudeen mentioned earlier. For the sperm, so you may be utilizing donor sperm. Donor sperm can either be known donor or from a sperm bank, an anonymous. The known donor has slightly more kind of steps to complete. So we would need to do the semen analysis to make sure there's enough sperm. They also get FDA required infectious disease labs. They also see legal and psychology, just to protect everyone's rights. Whereas the sperm banks, there are many different sperm banks and several large ones that is essentially done already. So it's a little bit less steps on your end. And the sperm donors can be queried based on pretty much anything, physical attributes, race, ethnicity, what they do for a living, education levels. And something to pay close attention to would be genetic carrier screening. And we can go through that in your visit. And that's essentially one option, which would be the IUI. And then I think Dr. Hoff is going to talk about another option.
Thank you. Hi guys, I'm Heather Hoff. I am going to be talking about IVF and reciprocal IVF tonight, but I want to say happy Pride Month. Thank you so much for joining us tonight. We really have a passion for this, and we're really glad that you're able to attend tonight's webinar. So in terms of IVF, I'm going to review just a little bit, with what Dr. Nurudeen and Dr. Clapp said in terms of the initial evaluation, and then the monitoring of the cycle itself and selection of sperm donors. So we'll address that as we go. But first, what is IVF? The process involves growth of multiple eggs at the same time in the ovary, collection of those eggs, fertilization of those eggs, growth in the lab where an embryo is created and they're grown for 5 days, and then transfer into the uterus. So I'm going to back that up and take that step by step. So the first thing, as Dr. Clapp was mentioning, typically you ovulate 1 egg per month as a woman. So when we do IVF, part of what we do is we try to recruit multiple eggs. So there are actually a group of eggs on both ovaries that start out the month, and they're all competing to be the one that's going to be ovulated. And typically one ovulates, one wins, and the rest of them dissolve. And the next month, there'll be a whole new group. So you can think of your ovaries almost like a vault. Like every month they will open up, let a certain number out. And that is the number that is in competition for that month. So when we do IVF, what we're doing is we're recruiting those eggs that are available, those follicles that are at the starting line, you could say. And so the way that we do that is we use injectable hormones. And these hormones are the exact same hormones that your brain uses to tell your ovaries to grow 1 egg. But now we're going to give you more of those hormones so that your ovaries will grow multiple eggs at the same time. So we would try to recruit as many as are available that are out of the vault for that month. And now the process involves those injections typically for 8 to 14 days. So some women need 8 days of medication, some women need 14. It doesn't make any difference in terms of the quality of the embryo or the egg. Now we would follow the growth of the eggs, just like Dr. Clapp mentioned in the IUI. We're going to do that with a transvaginal ultrasound and some blood tests for hormone levels. And we will make sure that everything is growing appropriately, that the levels are rising as we would anticipate, and make any medication adjustments as we need to. Once we see that the majority of the follicles or the fluid around the egg appear that they would contain a mature egg, that is when we would trigger. So a mature egg is an egg that once it's retrieved outside of the body, it's able to be fertilized. So we would do a trigger, and then we would plan a procedure called an egg retrieval or oocyte retrieval. And that is an outpatient procedure. It's done under anesthesia. And it's done with a transvaginal ultrasound. So just like the same ultrasound that's used for monitoring, except this one has a very, very fine needle, and it will collect the egg and the fluid. And at that time, the eggs will be taken to the embryology lab, where they will be cleaned off, fertilized, and grown out for the 5 days. And I think we have that coming up. So here you can see embryo progression. And so we start out with the egg as it's cleaned off, and we do fertilize with the donor sperm. And this is something that also, that we also use for egg donors, and I think Dr. Clapp will be also talking about that as well. But when we have eggs, we'll fertilize them with the donor sperm, and we will check in the next day to see how many fertilized. We'll check in on day 2 to 3, at which point they're usually 6 to 10 cells. And then we'll check in again on day 5 or 6, at which point they're now several hundred cells. This progression, there is going to be a natural selection. So it's going to decrease typically the number of eggs we get. Probably about a quarter of those will make it all the way to a day 5 or 6 embryo, maybe a third, just depending on, your age and other fertility factors, which Dr. Nurudeen talked about when we do your initial evaluation. At the day 5 or 6 mark, this is the time when we can consider also testing the embryo. And so testing of the embryo involves taking cells from the part that becomes the placenta and sending those off to look at the embryo chromosomal status. So confirming that there are a normal number of chromosomes. So we look for things like extra chromosome 21 for Down syndrome, extra 13 or 18 for Edwards or Patau syndrome, some other syndromes that children can live a very short life or have multiple deformities. We also look for any combination that means that this pregnancy automatically results in a miscarriage. And as part of the process, we do learn the sex chromosomes. Now you can decide you want to know those or not. You can decide you want to choose those or not. Any of those options are acceptable. Now, one of the very cool and unique things about, the testing I did want to mention too, that's totally optional. That's something that you can choose to do or not. And it's good for us to talk about that in the office because there are some factors that will come into play there, such as your age and the rates of abnormality of your eggs in general. So I wanted to say one of the very cool things about lesbian couples is that each couple, you have 2 potential egg donors and 2 potential carriers of the pregnancy. So as you imagine, there are a number of combinations. You can use insemination, you can do IVF on one partner, and you can do something called reciprocal IVF. And so reciprocal IVF is a process where both partners are able to physically participate in the pregnancy. So one partner will serve as the egg donor, the other partner will serve as the carrier of the pregnancy. It's actually what the process that my wife and I are currently undergoing. For the egg donor, basically one partner would go through the IVF process just as I've described, and would go through the retrieval. The embryos would be, the eggs would be fertilized with the donor sperm of choice. And then at that point, the other partner, there would be some evaluation to prepare for transfer of that embryo. So, Dr. Nurudeen mentioned the hysteroscopy. That's a very thorough way for us to evaluate the uterus, make sure that it's a happy home for an embryo with no polyps or fibroids or scar tissue. We do say that once you've invested this much in making a perfect embryo, we want to make sure that it's going into a perfect home. And so the preparation for the transfer excuse me, is actually, the initial part is relatively simple, especially compared to the injections of the IVF process with egg retrieval. So it involves estrogen pills and patches. And the purpose of those is to thicken the uterine lining. It also prevents ovulation from occurring. So the uterine lining becomes thick. We do evaluate that with an ultrasound to assure its appropriate thickness. And then we also do progesterone injections prior to transfer. And so, excuse me, we do those for 5 days. And so sorry. And then, yeah. And then we will do the transfer of the embryo. And we do it in the room with both partners available, and we do it under ultrasound guidance. And so it's really the culmination of both, and then we would follow the pregnancy for the first 10 weeks. And so we would do weekly ultrasounds and monitoring, and of course, both partners are encouraged to go to all of those. And so I'm going to get a sip of water and let Dr. Clapp talk about one of the other options coming up.
Okay, so the use of a gestational carrier is an option used by many of our patients. So if a patient doesn't have a uterus, or if a patient has a uterus but maybe has chronic medical problems that would preclude or make her pregnancy very high risk, or with a male couple, we would use the gestational carrier. So with a male couple, in order to accomplish their family building goals, we would use an egg donor and a gestational carrier. So the egg donors, we have an egg bank here at HFI. There are not as many egg banks in the country, obviously, as sperm banks, because eggs are harder to obtain. And you can use a fresh egg donor or a frozen egg donor. So a fresh is essentially you select an egg donor, and when selecting egg donors, it's similar to a sperm bank. You can, obtain information on race, ethnicity, physical attributes, prior pregnancies, education level, professional employment, etc. And if you're doing a fresh egg donor, then that patient goes through an entire IVF cycle, like Dr. Hoff mentioned. The eggs are obtained and then would be injected with the partner's sperm, or the male patient's sperm. Fresh egg donors are eggs that are frozen right now in our lab. So they've already been retrieved from an egg donor. And essentially they are then thawed and the IVF process resumed, like Dr. Hoff mentioned, to create embryos. So once you then have an embryo, that embryo then gets placed into the gestational carrier's uterus. So for a gestational carrier, we have a list of agencies that we use locally that we can provide to you. And you're essentially matched with a gestational carrier by the agency. She then is sent to us to make sure and confirm that she would be a good candidate. So ideally, a gestational carrier is somebody that's healthy, that's had children before, and hasn't had any complications in her prior pregnancy. And we would further then evaluate her by having her come in, going through her history, even reviewing her OB previous records, checking the inside of the uterus, similar to what Dr. Nurudeen mentioned with the hysteroscopy. And then we would do a transfer cycle. So that's where we would build up her lining of the uterus with estrogen and then place the embryo back inside the uterus. And then we essentially follow her for the first 10 weeks before she graduates back to an OB. And the nice thing about, a gestational carrier is, number one, you're matched with the agency. So, that you're obviously going to spend a lot of time with your gestational carrier. A lot of our patients come to the transfers for their carriers and come to the ultrasound visits and are even at the deliveries. So that is a great option for male couples. And then I think we're going to talk about another option, which is preservation.
So I'm going to talk about fertility preservation and our reproductive options for our transgender patients. Fertility preservation, just to explain what it is, it's the opportunity to freeze eggs, sperm, or embryos for later conception. This is recommended for those individuals who would like a biological child in the future. Right now, many transgender patients are of reproductive age or late adolescence. So at the time of their transition, reproductive options do come up. Many patients are going to want to consider having children after their transition. So ideally, we like to freeze eggs, sperm, or embryos before beginning the transitioning process, but we obviously can't always predict when that may happen. So it may not always be possible. Transitioning is unique and tailored to every individual. So depending where you are with your transition process, or we also call gender affirming care, physically or even emotionally, our practice is set to help with the planning and the execution of the freezing process. Some individuals may not have chosen to transition surgically, but may have started the process hormonally. And when this happens, the goal, we have to keep in mind that the goal of hormonal therapy is to maintain the normal hormone levels of your target gender. So this could affect the eggs and sperm production. So we usually will recommend our patients hold their hormones for maybe an average of 3 to 6 months before starting the freezing process. So I'm just going to go through what the options would be for transgender female versus transgender male. So if you're a transgender female, so male transitioning to female, we recommend that they consider 2 to 3 ejaculated sperm samples to produce enough adequate numbers of sperm to freeze for the future. We examine each collection and we divide it up into an appropriate number of vials that can be used for future insemination or future IVF. So if our transgender female has a male partner, we will help the couple plan for an egg donor and a gestational carrier. If the future partner is female, we'll discuss the option of IUI or IVF. When it comes to our transgender male, so these are females transitioning to male, we recommend egg freezing if they haven't undergone any removal of their ovaries yet. So if they are on hormonal therapy, we'll obviously recommend, like I said earlier, stopping the hormones before starting medication that we need for egg freezing. Ovulation usually returns in about 6 months for about 80% of patients. When it comes to egg freezing, just like we discussed earlier, you will take the injection hormones for about 10 to 12 days before the egg retrieval. And once the eggs are retrieved, you're done, they're frozen. For our transgender males, if the future partner is a male, we can fertilize the eggs with the partner's sperm, and they as a couple can decide if they want to have a gestational carrier. If the future partner is female, they can use donor sperm to fertilize the eggs. And they, of course, as a couple can decide the female partner will carry the pregnancy. This is very similar to reciprocal IVF that Dr. Hoff discussed previously. And that's pretty much it when it comes to fertility preservation and the family building process for our transgender patients.